All right, moving along. We've got Dr. Escobar is going to make his debut at boot camp for us. Yeah, coming all the way from Emory. He's going to talk about management of fibromuscular disease.
Thank you very much. So your board answer for your fistulas is 4 to 6 millimeters. 2 millimeters is pretty small. You got to be really good to do those fistulas. All right, so I got the even more glamorous topic of FMD. So fibromuscular dysplasia is one of those things that we all talk about, that we're going to be asked about. However, a few of us have actively treated more than one or two, even no matter how many years you've been out. So the obligatory pause of the slides, like that title slide. Oh, there we go. Okay, so unlike most other arterial diseases, this is a non-atherosclerotic, non-inflammatory occlusive angiopathy. So it's an illness of the arteries that generally affects, the classic answer is that it's a medium-sized vessel disease. However, it also affects so-called small and medium-sized vessels. And statistically, if you look at the grand majority of hypertension, over 90% of it is the so-called essential hypertension. Within the realm of 10% of secondary causes of hypertension, this is 10% of that 10%. So 0.1% of all hypertension is going to be associated to FMD of some sort. And it was originally described in 1938 by Ledbetter and Birkeland from Hopkins, and they found in a renal artery of a young boy who had severe hypertension, and they treated the best way they knew how to do in 1938 with a nephrectomy. However, they cured them. So we can cure people with surgery, although sometimes you have to remove a kidney. The cause is unknown. We've looked at this many, many different ways. We do know certain things. There's this concept that maybe that there's less vasa vasorum in certain vessels, and as these vessels are distended, or as the kidneys are being pulled and elongated and moving up and down as they're very mobile areas, maybe that there's a vasospasm, repetitive vasospasm, which leads to this medial hypertension, hyperplasia over and over. There's some association to smoking. There's also maybe a hormonal thing. We know that they're more common in women. About 3/4 of cases will be in females. And then there's some component that must be inherited, because about 10 to 11% of patients with FMD will have a familiar component to it. There's been some research about HLA, DRW6, and also some interesting stuff happening with angiotensin-converting enzyme polymorphisms, as well as angiotensin II receptors that may explain some of these familiar cases that have been aggressively looked at. Long story short is the histology, hence the name. We know that it tends to be more common in the distal renal artery, okay? So distal 2/3 of the renal artery, for some reason, doesn't happen in the proximal, unlike atherosclerotic disease, which typically is in the proximal portion. The medial fibrodysplasia is the most common. Now, I may have to say this again, because it will be on the V-site, and if you're at this course, you will get this question right, damn it, because I gave the class. So the other thing, this is like the actual pathology thing, which everyone forgets, but I'll explain it a little bit. There's like a collar of elastic tissue that just sort of randomly thickens, and it causes a series of little stenoses. In between the stenoses, it causes aneurysms, but interestingly, the internal elastic lamella is actually preserved. So when you look at the area of thickening, it's very impressive how thick they are with a hyperplasia, hence the name. But there's going to be these segments where the vessel is relatively intact. So this sort of intermittent sort of phenomenon is what gives it one of the characteristics with an angiogram, which we'll get to. And about 2/3 of them are going to be in renal arteries. The statistic will be important. And notice that medial fibrodysplasia is the most common cause, or the most common type. For some reason, the right renal artery tends to be more affected than the left. It can be bilateral in about 1/3 to less than a half of cases. And what it does is that it causes stenosis. Again, sometimes that stenosis can rip and it can tear and cause a dissection, although usually we do that with wires later, or it can cause an aneurysm. In the renal arteries, you can even start to damage the kidney, and we think that that has to do with microembolization, where like little, turbulent little eddies form, and then you start microembolizing and slowly knock off the kidney, and it gets smaller and smaller. And medial fibrodysplasia is the most common type. If you look at the 5 different types, I'd like to call your attention to the medial fibrodysplasia, which accounts for 80% of all the cases. And typically it presents with this that you're going to hear over and over is this concept of string of beads in the distal 2/3 of the artery. Now there's another type which also has the word medial in it, which is the perimedial, and that accounts for about 10 to 15. And if you add these together, you account for 95% of all cases. These other cases, I think, are from pathologists that had nothing to do, but I will say that there's a little bit of difference. You can have true full-blown FMD if you were to remove the kidney and look at it, and sometimes you're going to have these sort of long stenoses. So instead of that sort of intermittent stuff, you're going to have a long stenosis that on a microscope has a type of hyperplasia in the medial and in the adventitial areas. But long story short is medial fibrodysplasia is the most common kind. Now, 2/3 of patients with renal disease are also going to have affection, are also going to have their carotid arteries affected. Now, in the simplicity of a 10-minute talk, I'm just going to add this. It can be in a lot of vessels. Remember I said medial vessels has been described in iliacs, it's been described in other, vascular beds. I will say that if you find it in other vascular beds, you have to think of other etiologies of sort of spastic appearing vessels, and that can include other things that I'm not going to get into, which is non-atherosclerotic sort of inflammatory etiologies like Takayasu's or polyarteritis nodosum, et cetera, et cetera. But point is, 65% will also affect the carotids, and it looks just like the renals. This is a carotid artery. You can see the internal carotid artery and see how it's got these little funny looking things. Now, if you find it in someone with carotids, 2/3 of those patients will also have renal. So long story short, if you find the word FMD in a patient, look in the other vascular bed, because those two vascular beds, you're going to commonly find it in both. And in the carotid artery, it's the middle and distal part of the internal carotid artery, which gets back to this sort of weird thing. Why the ICA but not the common? Why not the external wildness? We don't entirely know the etiology, but there you go. And by the way, medial fibrodysplasia is the most common type. So within the history, you're tending to find a hypertension in a female, and I'll get to also the youth. They tend to be on multiple antihypertensive drugs for no apparent reason. Somewhere between age 30 and age 40 is the classic sort of presentation. There's some subtleties in this that I won't go into. They may even have an elevated creatinine, which may or may not be from actual damage or simply from the renal vascular hypertension. They tend to be young, and I put on here minus 30 or less than 30, but the reality is they can be anywhere between 20s to 40s is sort of like the middle point. But as you know from the first case that it was ever described, it can be in children as well. Other presentations could be pulsatile tinnitus. You're going to have a young person that says, God, I keep hearing whoosh, 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 pulsatile tinnitus, not ringing, but actual pulsatility. And you always have to think of a dissection and FMD within your differential diagnoses. It is one of the classic presentations is headache. We don't know why they have headache. It could be microembolic. We don't know. And of course, the granddaddy manifestations of the carotid is TIA or stroke. So once again, you get these little stenoses, you get eddies, you get clots, and you start having TIAs or potentially strokes. Within your physical exam, you're going to hear bruits. You're going to hear them in the abdomen or in the neck. The abdominal bruit would require that you have a stethoscope, and I would put money on the table that I could find less than 3 people that have a stethoscope in their pocket in their fellowship. Where's the 3? 1, 2, 3. That's it. Money's on the table. 3 people. No more. But you have to actually look for it. But it's actually kind of cool. If you hear a bruit, you're going to hear a unilateral bruit, and you're going to hear it on the side of the whooshing, right? Flash pulmonary edema in a young person minding their own business suddenly get pulmonary edema for no apparent reason. Whoops. No. Okay. The diagnostic screening or diagnostic test for screening of choice is going to be an ultrasound. Renal artery, again, the most common, so I'm going to focus on that. You're going to find either sort of a long stenosis or focal stenosis. I found some on the internet, but because this is being live streamed, I was a little hesitant to put it up there in case the guy or gal that published it might sue me. But the point is that you'll see a stenosis, and you may or may not see a increased resistance index. Now, you have to be careful because the resistance index is designed for focal renal artery stenosis. And when you have multiple segments, you may find an elevated velocity in the renal artery, but you may or may not notice a difference in the renal resistance index. I put this on there, but just look for stenosis. Multifocal stenosis in the renal artery, you've got to think of FMD until proven otherwise. If you go to an angiogram, and nowadays with a CT angiogram, you can also see this. It's even better with a CT angiogram because you avoid other things that look like FMD. But you'll notice up close the sort of lumpy, the so-called string of beads. This is a nice case because it actually has a second part to it. And if you see this, You get a wire and a catheter past it, and you measure the pressure distal to the little dealios there, and you measure the pressure proximal. And if you have a greater than 10 to 15 millimeter of mercury gradient, so it's a lower distally, then you know that the stenosis is significant and you should probably treat it. The standard medical therapy, like everything, antihypertensives and antiplatelet agents. You want to put them in antiplatelets so you avoid this sort of embolization phenomenon. Surgical therapy, you've got two big moves. You've got open and endovascular. Open is obviously, the standard, if you will, historically. However, endo is now going to be the standard of care. By the way, medial fibrodysplasia is the most common. You're going to get this right. I'm so excited. Okay, open repair. The classic approach for renal artery FMD is a bypass. Not most, I'm giving my bias. So I was trained at University of Michigan, and historically, every aortic and renal approach was transverse. So they used to call it the Michigan frown or the Michigan smile, depending if you went above or below the belly button. But a transverse incision will give you the greatest exposure to the kidney, a little to the left and a little to the right. If you're exposing the right kidney, you're going to have to lift up the renal vein, and you're going to have to pull over the vena cava. It's really annoying to do a right side. It's technically harder. If you do the left side, you just sort of cut the vein or move it out of the way. Depends what you have to do. Some people like to do retroperitoneal, particularly if you're going on the right side, because you can lift up and sneak behind the vena cava and the right renal vein. But anyway, so your standard, let's say you're going on the right side, you get a vein bypass is sort of your standard. Ideally, and you get your vein, you fold it, you split it, and then you do a sort of a side-to-side, wide-to-wide anastomosis there. Do the renal side first so that you know where your vein is going to land. If you do it the other way around, you may or may not have good length, but this is splitting hairs. You make a nice wide venotomy onto the artery, and you purposely put it lower. Look where the renal artery used to be, and look where it is now. That allows you to sort of lay it diagonally onto the aorta, so it sort of looks a lot wider than just trying to go end to end. So renal artery reconstruction, renal artery mobilized, right renal artery reconstructed. You can go retrocaval, antercaval. You can do your bypass over the vena cava. The problem with that is it'll tent down on the vena cava, and it can cause stenosis, which later will bite you. So try to put it behind the cava. You can also do an iliorenal if for whatever reason you can't go in there. Somebody else was there earlier and you need to go back and redo it. Then you can take it off the iliac artery and kind of go up that way. And you can use saphenous vein. If it's a child, you should probably use an arterial conduit, hypogastric or internal iliac artery as your conduit, so that it'll grow with the child. If you operate on a 13-year-old and you put a vein that looks good from a 13-year-old, that's going to turn into an extraordinarily tiny vein in a 30-year-old, and then you're going to have to redo it because now they have renal artery stenosis because the conduit's too small. If you use artery, it'll grow with them. You can also use prosthetic in an adult. When it comes to carotid artery, the classic description of an open carotid FMD surgery is that you open the carotid artery, you go through with dilators through the stenosis. Yes, you open the carotid and you shove dilators through the stenosis. You pop them. I've actually done this. You feel pop, pop, pop as you push it through. It's really weird, and I know what you're thinking. But the reality is that it works really, really well. However, angiography, if you have this, you get a wire past it, and it looks like that, and you get a balloon in it, and it looks like that. So you can save the subcostal. Here's another example, sorry, of a perimedial. So it's a very focal stenosis, and then you angioplasty, and it looks like that. So endo works pretty well. Is this accurate? So this is a series from Methodist, actually. And they looked at 41 patients, of which 21 actually had surgery. 100% of them had hypertension. And what they saw is that the primary patency, so without touching it and leaving alone, was 66%. But if they actually did stuff and sort of took care of the angioplasty, maybe got another angioplasty later on, they were able to keep it to 87%. There was hardly any restenosis. If you notice, the majority of restenosis occurred in the first 3 years, and after that, it really didn't happen. So in the end, endovascular therapy for FMD is effective, quite durable, and is the first-line therapy both in the neck and in the renal arteries. Surgery for, you just have to keep doing it over and over again, and or if they have big aneurysms, you're probably better off doing a bypass. And avoid stents in general because you can always do the surgical after. Most of these patients are young, they have pretty low risk. But if you do it and you mess up the artery and dissect it, then put a stent in. And medial fibrodysplasia is the most common. Thank you.